So that'd be like if group of you guys were studying in the cafeteria area, you'd be A&P students studying that outside of the science field area. Nerves, again, is one of those misused terms a whole lot, like wristwatch and so on. A nerve is actually a bundle of axons that are usually myelinated in the periphery. Spinal nerves are connected to the spinal cord. Cranial nerves are connected to the brain. The central nervous system, when we have a center is a collection of neuron cell bodies in the central nervous system, all with the same function. Like we would be a center, because we're all taking A&P1 at this very moment. So they're all going to have the same job. A nucleus is a collection of neuron cell bodies in the interior of the central nervous system, which may or may not have the same function. So every single center is a nucleus, but not every nucleus is a center. Okay, so that would be like a group of people hanging out in one area, but they may have different jobs. Okay. So a nucleus in the brain or spinal cord would be the same thing as a ganglia in the body periphery. Neural cortex, that is the gray matter on the outside of the brain. When we talk about higher centers, that's usually talking about the cerebrum or the cerebellum of the brain, mostly the cerebrum, the thinking components. Tracts, bundles of axons in the central nervous system. So again, you have nerves in the periphery, you have tracts in the central nervous system. But again, unfortunately, because nerves is such a commonly used word or phrase, we oftentimes will see it misused even in the book. They'll define it one moment and then forget that they've defined it and call it something else. So for testing purposes, nerves, again, bundles of axons in the periphery, tracts, bundles of axons in the central nervous system. And again, usually myelinated. Columns, those are the areas of the white matter within the spinal cord, and columns are divided into tracts. So you combine a bunch of tracts together, you get the column. Sensory or ascending pathway, again, ascending going up to the brains. It's going to be carrying sensory information from the body to the brain for processing. Descending tracts or motor tracts, they are going from the brain down to the rest of the body to control the rest of the body. Horns, that's the gray matter in the spinal cord. So it's made out of the unmyelinated axons, neuron cell bodies, and dendrites. And in the spinal cord, we've got white matter is called columns, gray matter is called horns. Those are just terms specific to the spinal cord. So in gray matter is going to be gray because we have all those mesial bodies kind of crammed into those cells. So anything that's not obscured or hidden by myelin sheath. So unmyelinated axons, dendrite cell bodies. White matter, myelinated bundles of axons. Okay, so when we look at white matter, we only have axons present in the white matter because that's the only part that's myelinated when we look at our cells. So the spinal cord is going to extend from the occipital bone, so where it pops out of the foramen magnum, down to the space between L1 and L2. So in an adult, it does not cover the entire length of the spinal column. Now, it is about 16 to 18 inches long and about 0.55 inches in diameter. So it's actually only about half an inch. It's very small considering how important that thing is. Now, in the beginning, because we have active neuronal development stem cells, our spinal cord will grow and elongate with the spinal column until the age of 4. The spinal cord stops growing at 4, so it's the same size now as it was when you were a 4-year-old, but the odds are you've kept growing, right? Right, I'm going to assume everybody in the room is bigger than they were when they were 4 years old. So what happens, again, the spinal cord doesn't grow anymore, but the spinal column continues to grow, and that's why it ends up between L1 and L2. This is one of the reasons why if you are a neurosurgeon, if you're a pediatric neurosurgeon, you have to have a whole lot more training because a 4-year-old spinal cord runs the entire length of their spinal column, where a 7-year-old spinal cord might stop in the middle of the sacral region. A 10-year-old spinal cord might stop at the lower part of the lumbar region. So depending on the age of that child and the height of that child, that spinal cord could be ending in multiple locations, depending on all those different factors. Where if you were just looking at adults, it's always between L1 and L2. So you have to have a whole lot more training to be a pediatric neurosurgeon. than you would have to be an adult neurosurgeon, just because of those variations in size differences and growth patterns in younger individuals. Now, if we were to slice and dice up the spinal cord kind of like a sushi roll, we would notice areas that are going to the upper limbs and areas that are going to the lower limbs would have a whole lot more gray matter, because there's a whole lot more information coming into and out of the spinal cord in those areas, because there's so many more neurons, obviously, in the arms and the legs than elsewhere. So you could tell where the arm information is coming in and out of. You can tell where the leg information is coming in and out of by looking at just the cross sections. These areas are called enlargements, so areas where we have bigger amounts of gray matter. So there's our spinal cord going from the foramen magnum down to the space between L1 and L2. The cervical enlargement is going to be upper area, because cervical's up there. So it's going to be found between C4 and T1, and this is going to provide us all the nerves and information going to the upper limbs. Our lumbar enlargement, even though it says lumbar enlargement, it's actually found in the thoracic region, again, because the spinal cord stops between L1 and L2. Okay, so it can't be in the lumbar region because there's no spinal cord really in the lumbar region of the spinal column. So it's going to be from T9 to T12 when we look at it, and it's going to go to everything below the belt, the pelvic region, as well as the lower limbs. Now, after the lumbar enlargement, the spinal cord is going to taper to a point, kind of like a sharpened pencil. And that taper is called the conus medullaris. So conus meaning cone-shaped, and medullaris meaning like center structure. Okay, so it's just this tapered conical portion. From that point, we're going to have lots and lots of nerves coming out the bottom of the spinal cord, again, going to the lower regions of the body. Those nerves all coming out are called the cauda equina. Cauda means tail, like caudal fin, and equina means horse, like equine signs or something. And that's because when you look at how those nerves just kind of stretch out from the bottom of the spinal cord, it looks like a ponytail. Okay, so that's what it means in Latin, is ponytail. So all those roots extending from the end of the conus medullaris downwards. So here's our little conus medullaris, kind of cone-shaped. And there's the cauda equina extending from that. They didn't highlight all of it, but it does include these little squishy parts. The filum terminale, again, filum meaning like string or filament, and terminal meaning the end, so the final string. So extending from the conus medullaris is this little string of connective tissue of pia mater that will extend all the way down to help anchor the spinal cord in place. It's going to form the core of the coccygeal ligament, and we'll talk more about components of the coccygeal ligament as we go through. Now, if we look at a cross-section of the spinal cord, on the anterior side, we're going to have a big crack. Okay, so that's called the anterior median fissure, which just translates to big crack on the anterior side. This fissure means big crack. On the posterior side, the back side of the spinal cord, we're going to have the posterior median sulcus. A sulcus is a little groove, kind of like when you're sulking, you're not all the way angry, but you're just a little pouty. Okay, so when you have a sulk, it's a little dent. When you have a fissure, it's a big dent. So the posterior median fissure, or excuse me, posterior median sulcus is just a little crack in the back. So there's our filum terminale extending from the conus medullaris all the way down. So there's our spinal cord. These are going to be your new besties. We do have a model that looks just like this, and we have a model that looks just like this. So we can see the spinal cord continuing down from the foramen magnum to the space between L1 and L2. And we have that conus medullaris right below the lumbar enlargement. And then we'll have that cauda equina, kind of looks like a horsey tail, popping out from there. And that final little string, that filum terminale, it's going to help anchor everything in place. When we look at that cross section, anterior median fissure, big crack in the front, posterior median sulcus, little crack in the back. Spinal nerves. We have 31 pairs of spinal nerves that contain both sensory and motor information coming to and from the spinal cord. So a lot of times you'll see them described as mixed nerves because they're carrying mixed signals, sensory signals and motor signals. Now, when we look at the spinal nerves, they are attached to the spinal cord via roots, just like the trunk of a tree attaches to the ground via roots. So we have two roots, the dorsal root and the ventral root. The dorsal root has sensory information coming in, so all the sensory neurons coming into the spinal cord are going to be found in the dorsal root. The ventral root is going to be all motor neurons, okay? So all the motor output leaving the spinal cord. So sensory comes in the top and motor comes out the bottom, makes a big circle, an arcing kind of structure. Now, the dorsal root will have dorsal root ganglia. So this is where we have the cell body of those sensory neurons. So the dendrites and the cell bodies are in the periphery. Their axons are going to touch the spinal cord. There it is again. So our spinal nerves, our dorsal root coming in the top, our ventral root coming off the bottom. There's the dorsal root ganglion that is going to be found on there. So that's going to have the cell body, so all the sensory neurons coming in, and there's all the motor neurons leaving. This is just kind of showing you a back shot. They've topped the spinal vertebrae, essentially. Now, one of the things to keep in mind, as we learned way back in the day, posterior and dorsal are interchangeable. Ventral and anterior are interchangeable. Now, some books like to use just dorsal and ventral exclusively. So when you look at this picture, you'll see that it says dorsal median sulcus. Okay. Now, your lab book is that way. It uses just dorsal, just ventral. You don't see the words anterior or posterior. Other books, other authors will use dorsal and ventral to denote peripheral tissue, so something in the peripheral nervous system, and terms anterior, posterior to note stuff in the central nervous system. So even though you can use the terms interchangeably, they like to use anterior, posterior as a signal of, oh, I'm using these terms, I'm in the spinal cord. Dorsal, ventral, oh, I'm using these terms, I'm in the periphery. Okay, and that's kind of how I look at things. So whenever I point to stuff, if I'm pointing to stuff in the spinal cord, I use posterior, anterior. So posterior median sulcus, anterior median fissure, anterior great horn, that kind of scenario. And then when I say dorsal ventral, I use that as a denotion that we're in the peripheral nervous system, the dorsal roots or the ventral roots. And so that's just something to keep in mind. So when you're looking at stuff like your lab book, and your lab book will say dorsal gray horn, and I say posterior gray horn, we're talking about the same structure. Your book just doesn't like to use the word posterior, anterior, it just uses dorsal strictly or ventral strictly. Make sense? Mm-hmm. So just kind of don't let it freak you out, because some people are like, that's not what the book says. It's like, and as we've learned, the book sometimes sucks. Right? So we just have a little bit different twist on things. So the meninges. So meninges, again, are those membranes that cover the outside of the spinal cord. And just like we saw with phalanges, meninges is plural. Menindrix would be single, so your X would be single. These are some of those twofer things. So we have the meninges around the spinal cord. We have the same meninges around the brain. So we'll see them now on test 4. We will also see them again on test 5. So our meninges all end in mater, which means mother, because it's kind of wrapping around taking care of the spinal cord. So our first one is the pia mater. Pia means tender. Okay, so this is going to be connective tissue that's very, very thin, very delicate. It's like saran wrap. It's clear. So whenever we dissect sheep brains in lab sometime next week, we'll be able to see the pia mater. Now, the pia mater is going to cling tightly to the brain and spinal cord, following all the nooks and crannies, and it's held in place by astrocytes. So the only way to remove pia mater is actually scrape it off of the brain or spinal cord, which would disrupt or damage parts of the brain and spinal cord. So it's held in place very tightly. And you'll also have some little tiny blood vessels going to the brain and spinal cord that are anchored in the pia mater. The arachnoid matter, again, arachnoid means spider, like, arachnids. That's because somebody thought it looked like a big spider web. It has a lot more collagen fibers to give it more support and stability, and they're just kind of crazy arranged, so it looks like a big spider web, like you would see around Halloween time. This one will enclose the subarachnoid space. So between the pia mater and the arachnoid matter, we have the subarachnoid space that is filled with cerebrospinal fluid. Dura matter. Dura means hard, like if something's durable, something's hard, it doesn't break down very easily. So this is, bless you, dense, irregular connective tissue, very, very thick connective tissue, very, very protective. It's thick enough that we can't see details through it. So you can't see all the nooks and crannies. You can't see the dorsal root or ventral root or anything like that. Just like paper bags are very protective of the contents they have in them. If you look at a paper sack, you can't tell what's in it from the outside, right? That's why they sell them in liquor stores, so no one knows what you got. It's a surprise. So that Duramat is very, very tough, very, very protective around the outside. So it's going to be our most protective layer of the meninges.
Did you say this the subarachnoid space is filled with cerebral fluid?
Cerebral spinal fluid.
Cerebral spinal fluid. Okay.
CSF. Okay. Now, the dura mater at the top of the spinal cord is going to anchor it to the foramen magnum so it doesn't shift position up there. At the opposite end of the spinal cord, it's going to continue past. So the pia mater, the arachnoid mater, the dura mater all extend past the end of the spinal cord. Again, that pia mater extension is the filum terminale. And they're all going to blend together to form the coccygeal ligament, which is basically going to anchor the bottom of the spinal cord, kind of like this little drawstring guy would anchor the bottom of the screen if I tied it down. So that prevents that spinal cord from shifting positioning or rolling up or moving, because that would obviously cause a lot of issues or damage. So here we have our dura mater. Again, so very thick, very protective, so we can't see any details past it. We have the arachnoid mater, kind of like gauze material or spiderwebby kind of material. And then we have our pia mater. Now, again, in real life, pia mater is clear like saran wrap, but you really can't see a clear membrane on a drawing. So they often color it pink. I don't know why it's always pink for pia mater, but it's just the way it happens to be. Okay. Anybody ever watched the movie Hannibal? Sequel to Silence of the Lambs.
Yes.
Right. So there's that great scene when they pop the top off of Ray Liotta's skull so they can eat his brain. The artist did a wonderful job reconstructing that. You can actually see Hannibal Lecter cutting through the dura mater and moving it and spreading the arachnoid mater out of the way to get to the brain itself. So they did a really good job of mimicking the cut through that to get to the brain and those structures. So wonderful job on their art department on that movie. Okay. There's our dura mater, and again, with it in place, we can't see all those things that we've seen on this previous picture. We don't see the filum terminale or the conus medullaris or any of those details because they're completely wrapped up and protected by that dura mater. On the outside of the dura mater, we're going to have the epidural space. Now, the epidural space isn't like air space. It's filled with packing peanuts, essentially. So it's going to have loose connective tissue. It's going to have some adipose to act as packing peanuts. It's going to have some blood vessels. This makes sure that we don't hit the inside of the vertebral arch. Okay. Now, at the top, it's going to fuse to the periosteum of the occipital bone as it passes through the foramen magnum. So the brain doesn't actually have an epidural space associated with it. Only the spinal cord does, because it's going to fuse to the periosteum and become continuous with the matter instead of being something separate. So no matter how good your epidural is, it's never going to make your brain shut down because the brain doesn't have that epidural space like the spinal cord does. Between the dura mater and the subarachnoid space, we're going to have the subdural space. This space doesn't have anything in it. It's kind of collapsed on themselves. It's recognized as a space because the dura mater and the arachnoid mater are separate from each other. It's kind of like there's a space, there's air between your shirt and your tummy. Even though your shirt is touching your tummy, it's not fused together, so there's still a gap there, right?
Mm-hmm.
Right. Nobody has fused shirt-tummy thing going on. Okay. So that's the subdural space. The subarachnoid space, as mentioned, under the arachnoid mater, above the pia mater, so in between, and it's going to be filled with CSF, cerebral spinal fluid. And this fluid floats the brain and floats the spinal cord because we don't want the brain touching the inside of the skull. We don't want the spinal cord to actually touch the inside of the vertebral arch because if we press neural tissue, which is very squishy against bone, it would crush neural tissue, and we don't want to damage the brain or spinal cord. Now, all these structures wrap around, okay? So you'll have the spinal cord with pia mater wrapped around, and then you'll have the subarachnoid space with CSF, then the arachnoid mater, and then the subdural space, then the dura mater, and then the epidural space around it. Now, that's going to provide many layers of protection and covering over the spinal cord, But for it to be very efficient, it doesn't need to shift position. Okay, it's kind of like pigs in a blanket. We've all eaten pigs in a blanket
Yes.
because it's delicioso. All right, so you got your weenie with the cheese and the biscuit, or if you're being fancy, the croissant. Okay, how do you keep your biscuit from jumping off of the weenie when you're cooking it? Toothpick, right?
Oh,
You stab the biscuit and the cheese right through the weenie so it can't move.
Hmm.
Not a big deal with the croissants because they like to wrap around, but biscuits like to be biscuits. They don't like to be biscuits. Okay, so you got to pin them to keep them in place. Just like we use a toothpick to keep those different layers around the outside of the weenie in place, we also use denticulate ligaments like a toothpick to keep these layers in place. So these denticulate ligaments are extensions of collagen fibers from the pia mater through the arachnoid matter and anchored to the dura mater. So that way you can't have a shift. The dura mater won't slide past the arachnoid matter. Nobody's going to telescope within the other one. They stay together, so they can't shift position. That's going to make sure that we don't have any lateral movement of the spinal cord, which could disrupt neural activity and cause damage. All right, cross section of that spinal cord. So our spinal cord, the gray matter is on the inside, the white matter is on the outside. And again, gray matter is unmyelinated axons, dendrites, cell bodies. And we have the gray matter separated into regions called horns. So we have the posterior gray horn on top. It is going to have the somatic and visceral sensory nuclei. So all sensory coming in, whether it's coming from your body or coming from your organs, will be processed by the posterior gray horn. The anterior gray horns are bigger or wider than the posterior gray horn, so they're easier to identify because of their size. They're going to have the somatic motor neurons. So every cell body that goes to a muscle cell to control that muscle cell. So again, every single skeletal muscle has a neuron that tells it what to do. The cell body of that neuron is found in the anterior gray horn. Okay? So it's going to keep it very protected because the only thing that could be exposed to the outside is that axon. So most of that neuron is protected in the anterior gray horn. Now, the lateral gray horns are going to have your visceral motor nuclei, so to control your digestive system or urinary system or anything like that. Now, the lateral gray horns are only in the thoracic and lumbar regions because that's where your organs are located, right? Your organs are in the thoracic cavity, the abdominal pelvic cavity, so we don't need them in the cervical region or the coccygeal region because that's not where your organs are located. So those are only specific to two areas. Now, anytime we see the word commissure, which we will see a lot in the nervous system, commissure means to cross over or a bridge. Okay, so the gray commissure is a bridge between the left gray matter and the right gray matter, so they can communicate back and forth to each other. So here's our cross section here, and we can see all those connective tissues associated to protect the outside. So the epidural space that has all the goop in it, fat and stuff. We've got the dura mater. We've got that very little subdural space. There's not a lot of space there. Then the arachnoid mater, this subarachnoid space that's filled with fluid, so the spinal cord is floating in there so it doesn't bump around. And we've got the pia mater clinging to the neural tissue, to the spinal cord proper. Here we can see the denticulate ligaments that are extending from the pia mater through the arachnoid mater to the dura mater. That way, everybody's kept in place. Even though the spinal cord is floating, it doesn't shift position. It's kind of like tying your boat down. So even though your boat is floating on the water, it doesn't float off into the middle of the lake if it's tied to the dock. Okay. Now looking at our cross section, here's our posterior gray horns that would have our sensory processing or sensory nuclei, our anterior gray horns that have the somatic motor nuclei, and the gray commissure. Now, in this picture, we do not see any lateral gray horns because this is the cervical region of the spinal cord. So there are 3 hints on this page, on this slide, that let you know that this is the cervical region. So what are 3 things on here that let us know that we're looking at the cervical?
The V notch.
Here you go. You got the bifid spinous process, so C2 through C6. What else we got? Transverse foramen. We've got those little holes that we only see in the cervical region. So of course, since it's a cervical vertebrae, we would not expect to see lateral great horns. Now there's one more thing up there that lets you know that this is cervical vertebrae. It's the easiest thing, which means very rarely does anybody ever notice it.
Is it, you know what?
Any guesses? The picture's labeled cervical. It's like, oh
Okay.
no. It's kind of like, how do I do this? Did you read the instructions? No. Yeah. So don't forget to always read instructions, always read description of pictures because they tell you stuff. So since this is a cervical, we know we're not going to see the lateral great horns. But the good news is you're able to recognize the elements of cervical vertebrae. So even if you didn't realize it, you learned something. Oh, come on. It's a good thing.
Yay.
Yay, we learned something. Okay. The white matter. Now, the white matter, again, is on the outside of the spinal cord, and it's going to be named based on its arrangement around the gray matter. And again, being white matter is made out of myelinated axons. And the white matter is known as columns. So we have the posterior white column between the two posterior great horns. We have the anterior white column between the anterior great horns. We have the lateral white column between the posterior and the anterior. The difference is we will have lateral white columns in the entire length of the spinal cord. So they're not isolated based on organs or anything like that.
The entire length of the spinal cord?
The entire length. White commissure, again, crossing over. So above and below the gray commissure, we will have white matter that crosses left to right seas. So that's our white commissure. Now, those dents that we saw, the posterior median sulcus, little crack in the back, anterior median fissure, big crack in the front, those cracks are within the white matter. So they don't actually touch the gray matter component. They are cracks in the white matter or grooves in the white matter. And of course, our columns are divided into tracks that we have running up and down. So there it is again. This one does have lateral gray horns. So it does indicate the posterior gray horn where we have the somatic and visceral sensory nuclei. So if somebody was to have spinal cord damage to their posterior gray horn, they would lose feeling in a part. So if I damage this part, I would lose the feeling in my right arm. If I damage this part, I might lose the ability to feel my tummy. Okay, that kind of scenario. Our anterior gray horn, that has the somatic motor nuclei into it going to all the skeletal muscle. So if we have damage to the anterior gray horn, we would have weakness and muscle paralysis. This is what happens with polio. Polio attacks the anterior gray horn, which is how it causes paralysis and then death of the individual because it wipes out the ability of the muscles to move. And when it hits the respiratory, when it hits the diaphragm, you can't breathe. The visceral motor neuron, so if we had damage to the lateral gray horn, we may not be able to function with our stomach, or our intestines may not function properly or contract like it's supposed to. So usually fatalities because you can't live without organs working properly. And there's our gray commissures. Our white matter, again, we have our posterior white column, our anterior white column, and our lateral white column. And above and below the gray commissure, we will have white commissure. And the dents, we've got the posterior median sulcus, little crack in the back, anterior median fissure, big crack in the front. Ooh, it's almost like we're going to have to learn this a lot.
Yeah.
And the good news is the models in lab look just like these pictures. Yay, just like the book.
Nice.
Ascending tracts. So bringing information from the body up to the brain for processing. So when we look at ascending tracts, we automatically know their sensory information because we're going to go up to the brain so we can process the sensory stuff. Now, the nice thing is some of their names kind of give you a hint. A spinothalamic tract goes from the spinal cord to the thalamus, which is a part of the brain. So we know we're going up to the brain. So even before we get into things, we know that this is a sensory tract because we're going from the spinal cord up to the brain structure. So our first one we have is lateral spinothalamic tract. It's on the lateral side of the spinal cord, and it's going to go to our spinothalamic tract, which is going to deal with pain and temperature. So a lot of times when patients have car accidents, they'll do like hot probe and cold probe tests. And they're like, can you feel this? You're like, yeah, I can feel you touching me. You're like, is it hot or cold? And if you can't tell the difference between hot and cold, you may have damage to your lateral spinal thalamic tract. Okay, so touch is a different aspect. It could be your ventral spinal thalamic tract. So you will have different types of tests to see, can you tell hot, can you tell cold, can you tell texture, that kind of scenario. Pain is also going to be in the lateral spinal thalamic tract. So if somebody had damage to that spinal thalamic tract, they may feel that they have a broken leg, but it doesn't hurt. Like it doesn't hurt, but it feels really weird. It's like, yeah, because the one that says ouch got damaged, and you can't pick that up for the body. Ventral spinal thalamic tract on the ventral side, it is going to deal with crude touch. Some people remember it as vague touch because vague and ventral both start with the V. So this just basically means that I can tell that this is smooth, or I can tell that this is rough. I can tell that something's touching me. You're not able to pick up the details with it. Okay, so you couldn't tell sandpaper from gravel. It would both feel rough to you. Dorsal and ventral spinal thalamic tract, so the ventral has two jobs. Dealing with unconscious muscle sense for controlling muscle tone and posture. So with our brain, it knows everything. It's always working. It's got all kinds of little bits and pieces doing stuff, but we're not always consciously aware of what they're doing. It's kind of like when you're using your computer and you're typing in Word, there's other programs running in the background, but you're not aware of them. You can't tap into them. So even though we are not consciously understanding this thing to be happening, the brain still can process it. So it's kind of like when we look at posture. Sometimes you don't realize you're slumping until somebody tells you, hey, would you straighten up? Anybody else have those issues? It's usually when you're typing on your computer, and after a while you start to look like Gollum and you're all hunched over your computer, and someone goes, hey, what's wrong? You're like, nothing. Okay? You realize, oh, I've got to straighten up my back. Okay? I've been slouchy. Okay? Some people are tilters, and they don't realize they're tilters because they're used to it unless they have pictures taken. Anybody else tilters?
Huh.
Yeah, I'm a tilter, which is fine until I look at pictures and I look like a parrot in all of them. I also cannot make eye contact with the camera, so all of my family photos, I'm like looking off in the distance somewhere. My kids are like, I'm glad I paid for these. Okay. And you know, it's not too bad unless you build stuff and you're like, that looks great. And someone goes straight in your head and you're like, oh, not level. Okay. Tilting problems. Anybody else tilters? There's people that are bobbers, and I've seen them. They do this when they sit still. I knew identical twins who were bobbers, but they bob differently. So when they sit next to each other, they look like a wave machine. It was like, whoa. They didn't know they were moving. They didn't feel it because the stuff wasn't being processed at the conscious level. It was traveling along a different track. So their brain did know that their muscles were contracting, causing that little bobbing action, but they weren't consciously aware of it. It's different routing. The gracilis and the cunate tracts. This is detail stuff. So touch, pressure, 2-point discrimination, conscious awareness of body position, muscle tone, so on and so forth. Now, 2-point discrimination is just like it sounds. So when they do the testing, one you can't watch because that's cheating. They have 2 points and they will touch your skin and go, how many things are touching you? And you're like, 1. And then they take those 2 points and they spread them about 1/8 of an inch and they touch you again. Like, how many things are touching you? 1. When you can feel 2 things touching you versus 1 thing touching you, that's noted. Areas that are very sensitive have very good 2-point discrimination. You can feel 2 different points or the separation of those points as small as 1/8 of an inch. For some people, it might be closer to 1/4 of an inch. Areas that are not as sensitive, it may take over 1/2 an inch before you can feel 2 things touching you. Okay, so this is one of the reasons why sometimes it's very frustrating trying to find something touching you. Anybody have issues with the hair? It's usually on your back. It's like, I can feel it. It's somewhere back there touching me. I can't stand it. And you're like, but you got lots of hair and it's all touching you. Like, no, but there's one. It's the one, right? Sometimes it's hard to find it because it's somewhere on your back and your back isn't very sensitive. Doesn't have very good 2-point discrimination. So you just kind of have to blindly grab at and try to find it.
That apply when you have an itch in your back.
Mm-hmm.
Okay.
That's why the itches are kind of like, something's back there. I don't know where, but somewhere. It's because it's not very sensitive. Your hand's super sensitive. It'd be able to pick that up very easily. So all these impulses, again, coming from the skin, the muscles, the tendons, the ligaments, joints, going up to the brain. So here's our ascending pathway. So there's the cunate and the gracilis tracts. Our spinal thalamic tracts are over here. We'll talk about the rest of these guys, the spinal cerebellar, next time. So we're learning them now. And these, again, are all a part of the somatic nervous system, sensory coming in and then controlling the body. So we'll revisit these. These are more twopers that will be on test 5 as well as test 4. And this is just kind of showing you somebody touched me, so it comes in through the dorsal side, processed through the posterior gray horn. It's going to travel up the posterior white column, cross over at some point, so we can go, somebody touched me. The descending tracts from the brain down to through the spinal cord to the body. So these are going to go to your skeletal muscle, so controlling whether or not we contract those. Our first group is the lateral and ventral corticospinal tract. This is the only one that is voluntary. Again, it's just like whenever you're using your computer device, whether it's a computer or a cell phone or whatever, these would be, you have the app that you're working with right now, but all the other apps that are running in the background you don't have access to. Okay, so the voluntary ones are the ones that you physically can control. So they're going from the cortex, so that's the top part of the brain, and it's going to go down to your body. So want to twiddle your thumbs? Use the lateral ventral corticospinal tract to do that. The rubiospinal tract and the rest of the guys are going to be at the unconscious level, subconscious level. So background apps running, that kind of scenario. So the rubiospinal tract starts in an area of the brain called the red nucleus. So that's how it got its name, rubiospinal red nucleus. So it's going to go to skeletal muscles to help them to contract properly for good muscle tone and posture. Now with this one, it's just elbows to fingers. So the distal part of your upper limb, so the forearm area. So what do your hands do when you walk? Do you slightly swing them? Do they flop there? Do you cup? Do you jazz hands? That stuff. Not super important for people because we walk on 2 legs, but very important for dogs and cats that run around on 4 legs. The reticulospinal tract, this one begins in an area of the brain what you call the reticular activating system. This is basically your on switch. Okay, so as long as you are conscious, the reticular activating system is firing, and the reticulospinal tract is sending impulses to your skeletal muscle, giving you muscle tone. So when you go to sleep, the reticular activating system shuts down, your body gets turned off, so you don't act out your dreams of being Muhammad Ali. Okay. This is the same one that causes you to faint. So when you lose consciousness, reticular activating system shuts down, reticulospinal tract shuts down, all power goes out to your muscles, there goes muscle tone, and you drop like a rock. Yes.
So is the jugular, or is there a main vein or artery that runs to this area?
No.
Okay. That's wondering.
What causes it to go to sleep when you pass out is due to carbon dioxide buildup, which changes the pH of your CSF.
Okay, carbon dioxide.
The vestibulospinal tract. So anytime we see the word vestibulo, it has something to do with balance and equilibrium. So again, when we're up and going, we want our muscles to contract enough so we can walk, but we don't want to be so contracted that we throw our balance off or we move and wiggle too much. So it's going to help us maintain the proper level of muscle contraction so we can balance properly as we're walking around. So here's the corticospinal tract, again, coming from the cortex, coming down, and eventually will cross over so we can tell the body what to do. Same thing, just different illustration, so we can tell the body. So we can see that they're traveling either in the anterior or the lateral corticospinal tract. They will then synapse on the somatic motor neurons in the anterior great horn. That will then lead to go to the muscles to say contract. Yes.
And what kind of cell is it that like stays in that little tube on the backside?
Yes, sir.
Go over to the right, to the left. I'm saying.
No.
Over to the left.
What tube are you talking about?
The little V tubes that go in. What kind of cell was that? That its nucleus stays in that little tubular area.
This guy.
The other one. Never mind.
Okay. So with these other guys, their cell bodies are right here, and those are their very long axons traveling down to the spinal cord.
Yes.
Oh, outside.
Yeah.
That's the dorsal root ganglia. So that's the cell bodies of your sensory neurons.
Okay, cell bodies.
So they're not in this picture because we're dealing with the descending tracts, which
Okay.
are motor and not sensory.
Okay.
But they would be hanging out right there. We saw them earlier over here. That guy.
Okay.
So that's the ends. So now we're going out.
Mm-hmm.
Here's our locations. So we have the lateral cortico spinal tracts on the lateral side of the spinal cord, anterior on the anterior side. That we're going to separate these areas as a safety mechanism, right? If they were right next door to each other and you damage that area, you'd be completely paralyzed. But since they're in different locations, if you were to damage this guy, you would have muscle weakness because you still have some control going on over here. Or if we were to damage these guys, we would have muscle weakness because we still have these guys intact. These guys are actually very hard to hurt because there's a big old vertebral body sitting right here. So you'd have to go through your vertebrae to damage these little guys. That's why a lot of these are tucked in right in this location, most protected area of the spinal cord. Okay, because you got to remember, tummy is over here and the back is over here. Mm-hmm. Okay. And then we have our other players, the rubiospinal tract, vestibulospinal tract, reticulospinal tract, tectospinal tract we'll talk about on test 5. We've got to learn a little bit more before we can fully learn about all the parts. Yes, ma'am?
So you said the reticular spinal tract, that's like present, or you have that when you sleep, right? Does it cause you not to move?
That's the one that shuts down when you sleep so you don't move.
Okay, so how does sleepwalking?
So when people sleepwalk and sleep talk, the reticular activating system doesn't shut down like it's supposed to. So it's a defect in the brain. That's why we see it more in children, because their brain isn't fully functioning yet and it's rewiring and so forth. So most people grow out of sleepwalking and sleep talking because their brain learns how to do its job as it gets older. But if you've got those sleepwalkers or sleep talkers, that's why they can be a mile away from the house and they never knew what went on because their brain was unconscious. Everything was working at the subconscious level, but they forgot to turn their body off, so they couldn't get it acted out.
Is there a way to slightly activate or like turn that on while someone's asleep?
Certain stages of sleep, you do move. So you'll roll over once or twice in your sleep. So you'll have different stages. Now, the stages that you're actively dreaming when you're in REM, this should be shut down completely, so you don't act out your dreams. So your brain is turning on and off throughout the night as it's going through. Kind of like if your computer's rebooting, it might turn the screen on and the screen goes off again, and then it has a little whirly guy. It's doing stuff even though you're asleep. Okay. Sleep paralysis is actually opposite. So whenever you wake up, your brain becomes conscious, but it forgets to tell your body to turn on. So that's what sleep paralysis is the reticular activating system forgot to be flipped on. So you're conscious and you can't move.
So it's like an actual thing rather than like a spiritual thing.
Yeah, that's why a lot of times when people are like the demons try to get me or the aliens tried to abduct me, you'll hear they all sound very similar. It's like I couldn't move. I could see everything going on around me. I could hear everything, but I could not move my body. It's like your thalamus was awake, bringing in sensory input, and your brain was like, I can do all the sensory, but I can't do the motor. And unfortunately, our brain tries to rationalize things. And for our brain, for some people's brain, rationalization isn't, oh, my body just isn't awake yet. Rationalization is the aliens are probing my anus or whatever thing is going on in their brain. Okay, so everybody rationalizes it differently.
So there's a truth tactic that you're shown in the military, where if you're holding someone hostage, one of the ways you can get them to tell you the truth is to come to them while they're asleep and talk to them in their sleep. And a lot of times they'll respond to you in your sleep. Like you got to get them to a point where they're sort of awake but still asleep.
So at that stage of sleep, the certain areas of the brain have shut down during the stage of sleep, but the reticular activating system's still operational, so they can control their body and talk to you.
Okay.
So you get them in that sleepy state where the consciousness, where they're thinking about feelings and processing, is already gone down for the night, but the body hasn't gone down yet.
Okay, gotcha.
So when she asked about sleepwalking, was that the same thing for sleepwalking?
It's just Your mouth is going instead of your body. It's still skeletal muscle. Yeah, that's why you can have that whole conversation and never knew any of it happened. And that's what happens with Lunesta. It shuts down those conscious parts of the brain so you can go to sleep, but that drug doesn't hit the reticular activating system. So your body can keep going just like if you were sleepwalking or sleep talking. It basically induces that state of mind. Brain, be so complicated. Any other questions? Oh, y'all are excited for next week, I can tell. You're asking brain questions. Woo. That's part of the nervous system, it's the brain. All right. That's zombies, right? They know. Brain. All right, so cerebral spinal fluid. It used to just be called cerebral fluid, and they're like, but it also flows around the spinal cord. They're like, fine, cerebral spinal fluid. Encompass all of it. So it is a clear, colorless fluid. It sounds redundant, but technically, if you look at it, Kool-Aid is clear and colored, right? You can see through Kool-Aid, but it's red or purple or whatever color your Kool-Aid happens to be. So it looks like water. Okay. It is a protective fluid, again, found in the subarachnoid space, floating around the brain and the spinal cord. So that's one of those two first. Volume, 80 to 150 milliliters, depending on the size of the individual and the daily circulation in that scenario. pH, about 7.35 to 7.4. So this is a number you will memorize in A&P too, because that's kind of the pH of you staying alive. When you get off of this number, it's not good for your body. Composition is similar to blood plasma because it is made from blood plasma. We'll talk more about how it's made and recycled on test 5. Again, learning more as we go through. But we're going to extract large volumes of material from the blood. So we're going to have a lot of water coming from the blood. We'll have proteins and urea. Again, proteins we can utilize to make neurotransmitters and repair cells. Urea is a byproduct of protein metabolism. Glucose, sugar, feed neurons, and of course lactic acid, because if you use sugar without oxygen, you build up lactic acid. We'll have cations, which are positive ions, sodium, potassium, calcium, and magnesium. Anions, negative ions, so chloride and bicarbonate ions. And occasionally lymphocytes sneak in there because they're sneaky little buggers, white blood cells, so they can fight off some infections.
So you said urea is a byproduct of protein synthesis, of protein breakdown.
Mm-hmm. Okay. So functions of cerebral spinal fluid. It's similar to what we talked about with the functions of synovial fluid. So first one is mechanical protection, right? When you do jumping jacks, you don't want your brain to hit the top of your skull. Mm-hmm. That'd be a good excuse, right? I'm sorry, I can't exercise. I don't want my brain to damage. So it's one of those things. It's going to float the brain, float the spinal cord so it doesn't bump on the inside of the cranial cavity, so your spinal cord doesn't bump around on the inside of the vertebral cavity. Chemical protection. Neurons have to have the perfect environment. They're like 4-year-olds, right? You don't drop them off at Thompson Park and go, okay, kids, I'll be back in a couple of hours. You ain't going to have kids, right? When you take your kids to public parks, there's the don't touch speak around. You're like, oh, gosh, they make rooms for that. Okay, so you got to make sure the area is clean for your kids to play. Same thing with those neurons. If we change sodium levels, that can cause depolarization issues. If we change potassium levels, that can cause repolarization issues. So we have to make sure the environment is perfect and pristine. So that's what that CSF does. It's going to flow around and making sure that we have the right levels of oxygen and carbon dioxide and all those ions and everything are where they're supposed to be so neurons don't misfire, so they can get the nutrients they need and be in a happy, healthy environment to work. And then, of course, circulating, as we're circulating, we can deliver them sugar so they can run. We can deliver them protein so they can build neurotransmitters, and deliver them oxygen. We can take away waste and carbon dioxide. So when you have an awesome weekend, part of the lag time the next day after your awesome weekend, one, you've released too much GABA during the awesome time. Now you're anxious and have little anxiety issues because you don't have enough GABA. And two, the irritating headache is because your fluid is having to circulate and flush the system. So whatever you were doing over the weekend that affected your brain, it's got to flush it and get rid of it. So it's going to have high amounts of waste product in it. It's not going to have as much water in it. So it can cause that headache and that problems that we might associate with that hangover the next day. So it cleans up your mess.
So is this can't spinal fluid leak out of you? Mm-hmm. Okay. And is that caused because your pH is thrown off, or?
It depends. Usually it's because you've sprung a leak.
Okay.
So this is why whenever there's car accidents, one of the first thing paramedics do is look in people's ears. Okay, it's not because they're checking your hearing. If there's clear fluid, you've had such a severe head injury, you've torn the CSF and it's drained into your middle ear cavity and coming out of your ears. It could also drain out of your nose. There was an instance where a lady, she just thought she had a really bad runny nose and had headaches, and she's like, oh, severe sinus headaches. She'd wake up and her pillow would be soaked, and she thought, wow, I'm really snotty. She actually had a car accident, and it caused a micro tear in the dura mater right by the nasal cavity, and she was leaking CFF into her nasal cavity. So they had to go in there to stitch it up, and her headaches were because the membranes were rubbing because they didn't have enough fluid. So it can leak out, and of course, not only would that lose fluid, but that could introduce ways for pathogens to get in, which can be another health concern.
I thought if you leak spinal fluid into your body, I thought that causes like hallucination. No, maybe I'm wrong.
No? You're like, well, what are you doing to do that one? Now, when you do certain drugs, that drug will float around in your CSF. So as long as it's in the CSF, it's going to keep freaking out your neurons and changing that chemical area, and they're going to be, woo, too much fun. But yeah. Now, if you have problems with your CSF, it can cause other health issues. All right. Lumbar puncture or spinal tap, not the band. Okay. So this is when you have to remove fluid, remove CSF for testing. So you're going to do this in the space between L3 and L4 or L4 and L5. So we're going to hit this space for two reasons. One, it's below the spinal cord. The spinal cord ends at L1, L2. So that means the risk of damaging the spinal cord should be 0 because we're stabbing below the spinal cord. Now, we can still hit some of the nerves in the peripheral nervous system. That can cause problems, but the damage won't be as severe or as permanent if we were to hit the spinal cord. We also want to aim here because the subarachnoid space here is a little bit bigger, kind of like the bulb at the end of a thermometer. So it gives us a bigger target and a safer target to extract that fluid. If we were to do a lumbar puncture at home, which you're not going to do one at home, all you would have to do is draw a line across the highest points of your iliac crest. That line should pass through the spinous process of L4. So they'll fill right above or right below to do that. So those you'll have, if someone needs to do a lumbar puncture or even an epidural, the difference between the two is depth. Epidural, you're going to have the same needle. It just stops at the epidural space to numb you. If it's a lumbar puncture, you just continue a couple more millimeters and hit that. So that's why it takes a lot of skill to be that person to stab pregnant women in the back. Because if it's too deep, it'll cause a lumbar puncture, and you don't want that. That's very painful. And then, of course, leaky fluids and stuff like that. You have to have the right depth to get it to where it needs to go. So if you've ever had an epidural or lumbar puncture, they'll usually tell you to bend over and touch your toes and don't move, which is horrible if you're pregnant and in labor because you haven't touched your toes in months and you're trying to bend over and touch them and not move, but you're in severe pain because somebody keeps trying to get out. Okay. You're like, really? No, don't move? Whatever, good luck. And then they kind of stop and hope for the best. So why do we want to remove fluid? It is dangerous. You can cause neurological damage if you hit some of those nerves just right. You can sever a nerve if you hit it just right. And of course, by opening up a tear, that could allow a pathogen or something in. So we're only going to do these if we absolutely necessarily have to do it. So one, withdrawal fluid for diagnostic purposes. This is the only way to diagnose if you have meningitis. Okay, so if you draw the fluid and there's little bacteria floating around in the CSF, you do have bacterial meningitis, and you better hurry up and save your patient because they're about to die, because that one will kill you in less than 24 hours. So you can identify the difference between fungal or viral or bacterial meningitis by what's floating around in the CSF. You can see if there's been injury, there might be bleeding. If there's blood in the CSF, that can be major tears or problems either in the brain or spinal cord, stuff like that. So disease finding ability. Introduce antibiotics. That blood-brain barrier is so good at keeping the outside stuff out, medication can't even get to the brain and spinal cord to help you out. So if you have that bacterial meningitis, you can't pop a pill with the antibiotics. You can't get an IV with the antibiotic. It's not going to get to where it needs to go. It has to be shoved in through a lumbar puncture. So we have to deliver medicine via this way to bypass the blood-brain barrier. That's going to be the same thing for chemotherapy. A PIC or a central line isn't going to help you with chemotherapy because it's blocked from getting to the brain. And of course, if you want to put yourself to sleep, you got to bypass the blood-brain barrier by going directly into the puncture there. We can also introduce contrast media. This could help us see if there's a leak because, again, it's clear fluid. So if it's coming out of your nose, sometimes snot's clear. And you need to be able to tell the difference. You can culture it and hope for the best. But, of course, if you put a contrast media, you can see a flow and you can see if you're leaking or if there's a clog or if there's a obstruction or damage somewhere. You'll be able to see that. And sometimes we just need to measure pressure. Too much fluid will crush the neural tissue, can cause cellular damage and death. Too little fluid causes the membranes to rub on each other, causes the tissues to settle, and that can press, causing damage. So it can cause seizures and a lot of other health concerns if you don't have the right level of fluid. Okay. Question about spinal cord? All right, spinal nerves. So around the outside of our spinal nerves, we're going to have layers of connective tissues, just like we saw with the muscles. So the good news is the beginning parts of the words are just like what we've seen with the muscles. The bad news is now you have to read the whole word because I could ask you, what do I call the connective tissue around a bundle of axons? And I can put perimysium. Oh, tricky. Got to be perineurium. Okay, so we have to read full words, not just the first part of the word anymore. Okay. So epi, again, outside, epineurium, neurium is nervous tissue. So this is the dense, irregular connective tissue around the outside of those big nerves. Perineurium, it's going to enclose a fascicle. So the term fascicle just means bundle of. It can be a bundle of muscle cells when we're talking about the muscle system. It can be a bundle of axons when we're talking about the nervous system. Okay, so you just have to fully read to see what kind of fascicles we're talking about. Endoneurium, they surround a single axon. So there's our guys, similar to our picture, but instead of a giant thigh muscle, we've got a giant spinal cord lurking in the background. So we've got the epineurium, the perineurium, and around each individual cell, we would have endoneurium. Now, when we look at our spinal nerves, again, we have 31 pairs. The cervical nerves, we have 8 pairs of cervical nerves. That's compared to 7 cervical vertebrae. So we have an extra set of nerves because a nerve pops above the atlas and then below the atlas and then below the axis and below. So we've got that extra one on top. So we've got 8 cervical nerves. The thoracic, lumbar, and sacral match the vertebrae. So 12 thoracic vertebrae, 12 thoracic nerves. 5 lumbar vertebrae, 5 lumbar nerves. 5 sacral vertebrae fused into 1, 5 sacral nerves. The coccygeal, we just have 1. You don't need to have 4 different nerves down there just for your little nubbins. Okay? So the C's don't match the vertebrae. So when we have the spinal nerves, again, that's kind of like a tree trunk, and tree trunks attached to the ground via roots. So our spinal nerves are going to attach to the spinal cord via the roots. Again, we've got the dorsal root that has the sensory information coming in. We'll have that dorsal root ganglia that has their cell bodies. Then we're going to have the ventral root. The ventral root is going to have the somatic motor neurons and the visceral motor neuron axons. So again, sensory information is coming in through the top. Motor information is leaving through the bottom. Now, the spinal nerves are mixed. They have both sensory and motor, and they are fairly short. Just like a tree trunk, when you look at a tree, the naked part of the trunk is only a small amount of that tree. Most of it's big branches and big roots. Okay, so from the spinal nerve, they're going to branch out into structures called rami. So we learn rami or ramus means arms. Okay, so arms are branches. So we're going to have the dorsal rami and the ventral rami. Dorsal rami are kind of thin and delicate. They're going to go to the posterior body trunk. So they're only going to go basically, if you were to draw a circle around the vertebrae, that's about where the dorsal rami are going to. So very thin, tiny muscles like the spinal or the erector spinae muscle. The little guys we didn't have to care about because they were so little. Ventral rami go everywhere else. The rest of the body trunk, the arms, the legs, the heads, everything but that one little strip down the middle is going to be ventral rami. And again, of course, ventral rami, since we're going to so many more places, they're much, much bigger. So if we were to use A&P terms to describe them, the roots lie medial to and form the spinal nerves, and the roots are either sensory or motor. Our rami lie distal to and are lateral branches of the spinal nerve, and they have both sensory and motor information coming through them. So here's our picture. So we can see our spinal cord. Here's our dorsal root with sensory coming in, ventral root with motor coming out, dorsal root ganglion. There's the spinal nerve, fairly short, just enough to clear the vertebrae. And then we almost immediately branch into the ventral rami, which are very large, and the little dorsal rami, which are little and wispy, just going to the posterior body trunk. Big bad hairy questions?
Dorsal small, ventral large.
Yep.
Okay.
So here's
Rami.
showing the sensory stuff coming in. So we have visceral sensory is the dark blue, somatic sensory body is the red. So we can see it coming through the different rami. And then we have our spinal nerve and then our dorsal root. Cell bodies are found in the dorsal root ganglion. And their axons will synapse onto either the somatic or the visceral sensory areas. On the way out, we've got, again, the somatic motor neurons with their cell bodies in the anterior great horn. They're going to leave as a part of the ventral root and go out through the ventral and the dorsal rami to control the body. The visceral motor neurons have their cell bodies in the lateral great horn. Their axons leave as part of the ventral root, but they're only going to go into the ventral rami. So why do you think all the visceral motor neurons are going to be in the ventral rami and not in the dorsal?
So can you move your
The light blue guy.
do that again?
How come the light blue guy only goes to the ventral and not the dorsal?
Ventral, dorsal. I'm just gonna. That's a great question.
Isn't it though?
I thought maybe just because it's harder to travel up or travel to the back way, I guess. Because would it have to make
Where are the dorsal rami going again?
to the ventral root? They're going to the
Which
So it can't go because it's only, because the ventral goes to the limbs.
you're getting it, you're getting it. So the dorsal rami goes to the posterior body trunk, right? How many organs are in your posterior body trunk? Any organs along your spinal column area?
no.
0. Okay. Visceral motor neurons go to your stomach and your intestines and your lungs and liver and your organs. All your organs are in the ventral cavity. They're going to be in the ventral rami, okay? Because there's no organs between your skin and the vertebrae. Okay. Dermatomes. You can kind of think of dermatomes kind of like front yards. Okay, you've got your front yard, and your job is to keep your front yard nice and clean. So you probably mow it, throw away trash. If somebody gets in your yard, you notice it. Now your neighbor might be Wild Kingdom, but that's none of your business because that's their yard. You worry about your yard, right? That's what the dermatomes are. They're the yards for your spinal nerves. So if you're T1, your yard is this one area, okay? So it's going to go across the body. And that's the only area you're going to monitor. That's the only area you're going to care about. Nobody cares about the belly button because that's not my yard. That's somebody else's yard, okay? So those different regions are going to be monitored by those different nerves that are coming off of the spinal cord. This is why parts of your body fall asleep. If you cross your legs wrong and you pinch that spinal nerve on its way to its destiny, its location, it's going to not be able to fire properly because you've pinched it. Just like when you pinch a water hose, it can't fully run. Just a little bit, it spurts out. So you get the tingling and the numbness. And then when you let go of the pinch, then all of a sudden you get this weird feeling back to it. Okay, that's because you've pinched that one little nerve. So you're not getting the full picture from the dermatome until you stop pinching it or something. These dermatomes we can use to help to identify if there's damage to the nerve. So if I go in and go, doctor, I can't feel my pinky, they know exactly who to go look at because that dermatome associated with that pinky belongs to a specific spinal nerve. So they know exactly who to go view to see, oh, you slept weird and you bent your neck funny and it pinched. That's why you can't feel your pinky anymore. So you have to alleviate the pressure, move stuff around, pop your neck, and it should start to feel better, that kind of stuff. Some diseases will also follow dermatomes. Okay, so shingles and chickenpox and herpes and those guys, they all follow dermatomes. Okay. Your spinal nerves, everybody except for T2 through T12, the ventral rami are going to join together, crisscross, redistribute, forming these nerve plexuses. So it's groups of nerves that like to work together so they can do bigger jobs. Okay, so as we've learned, parts of your body likes to work together so you can do bigger jobs. So here's a dude and his dermatomes. Now these are just the dermatomes associated again with the spinal cord. Your face has different ones because of cranial nerves. So again, if I slept funny and I can't feel my pinky, I would go look somewhere around C7. Okay, that's what I'm pressed. That's where my issue might be having. As we talked about with the herpes, so shingles, chickenpox, same thing. Genital herpes and cold sores. Herpes viruses all have the same ability to crawl along the dermatomes. That's how they got their name. That virus lives in dorsal roots. That's why chickenpox itches. Itching is a precursor to pain. And when you get chickenpox as a kid, you're not fully myelinated, so you can't feel the full effect of chickenpox. When you get shingles as an adult, that stuff is painful because that nerve is fully myelinated, so you can feel the entire wrath of that sensory nerve on fire because that virus is spreading along that sensory nerve. So if you've ever had one of those, whether you get shingles or you get a cold sore, you get genital herpes, your business, you'll know when it's happening, right? Right before the sore pops up, you get the weird feeling or the pressure or it's odd, it tingles funny. I bet it's going to be popping up in a minute. Anybody else cold sore issues? You know it's coming, the tingling though. And that's because once you've got that virus, it lives in your dorsal root for the rest of your life. That is your new friend. You'll never get rid of it. So if you've had chickenpox as a kid, you're never going to get it again because you've already got it. Now, if you get shingles, it's because you forgot to tell your chickenpox to sit down, shut up, and take it. You didn't suppress it, and it came out. It's like you're not watching your dog, and it gets out of the fence and goes crazy. Okay, so that's why you always see those commercials like, if you've had chickenpox, you've already got the virus that causes the shingles. You're like, wow, you're an ominous little voice, aren't you? Okay, that's because you do. You've got it. It's sitting there waiting to come back out. And that's why when we get sick, we get tired, we have fevers, we get stressed. That's when we get the cold sore. That's when we get the shingle pop out. That's when your genital herpes goes, hello. It's because when you're healthy, you keep it suppressed. When your immune system dips, it gets distracted by the flu over here. And then while your immune system is attracted by that flu, your herpes is like, dude, they're not watching. Go for it. And it activates and it travels down the dermatome and you get the blisters. So herpes for everybody. And then you got to come back over and slap down that herpes and suck it back in, bring it back into the system, use that medication. Okay, so this is how you can track it. So some people, they'll have them reoccurring in the same locations. Like, I'll always get the bra line. Well, that's your T4. He's the one that's going to be the problem for you. You get genital herpes and cold sores have to have a moist way in, where shingles doesn't have to have wetness. You can just do skin-on-skin contact for shingles. But with the genital and the mouth ones, they do have to have some moisture to allow them in. So your genital herpes lives in S2, S3, and S1. So this is why you'll hear some people who have genital herpes, when they have an outbreak, they're like, I have to wear special socks. I have to wear soft pants. And you're like, why do you got to have special socks? Because your junk's got problems. Because S1 over here comes all the way down the back of the leg. Okay, so does S2. So the same one that's going to give you a blister on your penis is the same one that's going to make the back of your calves feel funny until that blister goes away. So some people, they'll get that full sensation along the entire dermatome, not just in the genital region. If you've got cold sores, those are usually in your cranial nerves. That's why they're not labeled up here. And that's why you tend to get the sore in the same spot every single time, because that's where that problem child is. It's like it's always that one dog that gets out. It knows. So you can track those guys looking at those dermatomes. Okay? And that's why they tell you, don't kiss babies. You can give them the herpes. Most of us already have it. If you didn't get shingles or chickenpox because you were vaccinated, you just have to worry about getting it now. Cold sores, 8 out of 10 people already have the cold sore virus. Most of us keep it suppressed, and it only pops out when you're having a really bad day. So some people are like, well, I've never had a cold sore. It's like, well, good job. Your immune system's good at keeping it in, right? But you probably already have it. With genital herpes, I've seen numbers as low as 1 in 8, as high as 1 in 6. Okay, so a lot of people have genital herpes, but again, you can never have genital herpes and never have an outbreak. It's just your body keeps it suppressed, but you picked it up somewhere. But once you got a virus, you got a virus for the rest of your life. It's a new friend.
So I heard something once that because of the hormones that we, like modern times, we've been pumping into our food is where that virus came from.
It's been around for centuries.
Hmm.
Yep. It's, if I'm remembering correctly, I think herpes is one of the special things the Europeans brought to the New World. It's okay, syphilis came from the New World, so take a native person for syphilis.
So are cold sores the same things as like oral surgery?
So fever, blister, cold sore. One of them simplex 1, one is simplex 2, and they just need moisture to pass so they can go back and forth. So if you have a cold sore and you perform on your spouse can end up with cold sore herpes on their junk.
Oh my God.
So you can be like, I don't have genital herpes. This blister, no, that's oral herpes. I'm like,